Hello and welcome to
everyone.
today's webinar, Mastering the Simple Stuff, Addressing Challenges in Healthcare Innovation. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen. That's F5 on a PC, or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box that you see located at the right side of your screen and pressing Enter there. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today moderator Katie Davis, Vice President of Provider Relations at CAQH, Patrick Murtaugh, Vice President of IT, Clinical Product and Platform Architecture at Centene, and Meredith Williams, Vice President of Clinical Affairs at Oscar Health. At this time, I'd like to turn the floor over to our speakers.
Thank you. All right. Thank you, everyone, for joining us today. Before we start, I'd like to take a moment to acknowledge the tragic loss of Brian Thompson, CEO of United Healthcare, which deeply impacted our community this past week. Brian was a well-regarded healthcare leader who, in his own words, was committed to making healthcare easier for people, a goal many of us share and work along United Healthcare to achieve. UHC has been a valued partner to CAQH and is represented on our board by Executive Tim Kaja. Our thoughts are with Brian's family and the entire UHC team during this difficult time. Thank you for taking a moment to reflect with me on the significant contributions Brian made to our industry. His commitment to making healthcare easier for people aligns with the very challenges we're here to address today. While innovation continues to capture headlines, the healthcare industry still struggles with mastering fundamental challenges: patient access, including scheduling and credentialing, network management, and achieving true interoperability and data sharing. In today's session, we'll explore learnings from other industries, identifying opportunities where incremental evolutions of the current state can drive significant progress rather than focusing solely on disruptive revolutions. We'll also dive into the importance of team-based approaches to solve these challenges. And with that, I'm excited to share that with us today, we have experts representing both technology and clinical perspectives to provide a well-rounded view. I'm going to introduce our esteemed panelists, or really have them introduce themselves at this time. Meredith, would you start us off?
Sure, happy to. My name is Dr. Meredith Williams. I am the Vice President of Clinical Affairs at Oscar Health. I also am a practicing emergency physician at Metro Health in Cleveland, Ohio. I've had the privilege of being in industry and in health insurance for over a decade, and I'm very excited to be here and look forward to this conversation.
Thank you, Meredith. Patrick?
Hello, everybody. I'm Patrick. I'm thrilled to be here as well. I am the Vice President of Clinical Product and Platform at Centene, which is a relatively new role for me, just about a month in at this point. But I do have about 25 years of healthcare experience, going back to the early days of interoperability and integration. My focus has always been on case management, utilization management, clinical workflow, clinical business roles, the EDI HIPAA transaction set. I am obsessed with provider and payer interoperability, so I'll go on record because you're going to hear that throughout the session today. And also a passion for just straight up interoperability. So I do a lot of work in the industry with groups like Da Vinci and the HL7 accelerators and those types of folks. About 3 years ago, I did try to go way outside of my comfort zone and became CTO of a digital therapeutics organization, which created software as a medical device for folks with anxiety, depression, substance abuse, and recently came back to my roots. So glad to be here.
Thank you, Patrick. And just a little bit about me. I am your moderator for today's session, Katie Davis. I'm a nurse practitioner by background, have spent the last decade building and scaling 2 technology-enabled healthcare services organizations. Following that, I launched a consulting business and recently joined CAQH as our first clinical hire, serving as the Vice President of Provider Relations. All right, so we did already touch on what we are going to be covering today. So let's look at some of the statistics. Healthcare administration costs continue to skyrocket. Won't highlight everything here, but 30% of healthcare expenditures in 2022 were driven by administrative costs, and 265 billion are noted in healthcare administration waste. As we jump in to our presentation, we want to do a quick poll here. So for those that have joined us, what do you feel are the most pressing simple things that still need to be solved in healthcare? You can use the poll to choose your responses. We'll give folks just about 20 seconds here. Getting some more responses coming in. Give folks a little bit more time. All right. Let's close the poll and we can publish our results. All right. So everyone should be able to see the results over there in the chat. So 59% of you said patient access, 14% of you said network management, 18% on interoperability and data sharing, and 99% on tech that delivers real impact. For those that identified patient access, why don't we dive into that one first? Meredith, do you want to talk a little bit more about patient access and maybe even touch on network management? When I think of these things, scheduling is one of the first things that comes to mind. And with that is also probably credentialing in the mix as well. But why don't we dive a little bit deeper on that topic first?
Yeah, so it's a great question, and I definitely agree with the folks who put patient access and network management at the top. I think it's a huge issue right now. You know, it's interesting to link the two because traditionally, particularly in Medicare, network access really was part of the way of thinking about, network management was part of the way you thought about access. Time and distance standards were created so that people would have accessibility. They would be able to get to a clinician of, any type, any specialty within a certain reasonable time and distance of where they lived. Those parameters are still in play, but nevertheless, we're seeing quite a number of folks saying, I can't get in. And that, I think, is a result of other trends that have really played out over the last decade and really, frankly, been accelerated after COVID. One is, I would say, some of the degree of provider consolidation. We are seeing a real transition in the clinical practice community. We're seeing the rise of what's now being called hospital deserts. We've seen this in the network world where there have always been parts of the community where it's been challenging to meet even just adequacy standards because you couldn't find a specialist in that area or that part of the country. They just didn't exist. Those issues have gotten worse, not better.
Definitely. Thank you for that, Meredith. And may have lost her for just a second here. So one of those key things that Meredith touched on was really this provider accessibility and the challenges there. 40% of Americans report unreasonable healthcare wait times. And I think probably one of the even more concerning components of this is that 50% of those reporting unreasonable wait times never actually ultimately seek care. So wait times can be 1 to 3 months at best. I know in some of my clinical practices that I've worked with, we have tried coordinating for patients to get into primary care, and that in of itself is over a 3-month wait. Patrick, do you want to touch a little bit on how technology solutions may be able to support here?
Yeah, absolutely, Katie. And one of the things that I want to call out, I think we all agree that we've got a provider availability crisis, right? People can't get to see physicians, right? And what is really unfortunate about this is that the underlying technology, which allows us to schedule and look at slots and start looking at network availability and those types of things exist, right? But we're not using them to their full advantage. So we've proven inside of labs and that type of thing that we can ping EHRs, we can use the patient access APIs to determine provider networks and is this physician in network for a specific patient. So the technology, the underlying technology with the APIs and other types of data integration is showing a lot of promise. What we need to do collectively is recognize that we've got a technical base. It's not perfect, but it's going. And how do we create inter-actor cooperation to start using that? And I am really excited to say I had a meeting with a group about a month ago that's using some very innovative technology APIs to start pinging different providers, across based upon geography and that type of thing, and doing kind of a search for scheduling openings at scale, right? So not just, okay, is Dr. Davis available next week? Is it Dr. Davis or anybody in that network that would be appropriate for that particular patient? So certainly work to do there, but the underlying underpinnings that we've been working on from a technical and use case perspective for many years are starting to show some value.
Awesome. Thank you, Patrick. I think, Meredith, we lost you for just a second there, mid-comment, but we were talking a little bit about some of the technology opportunities that exist around some of these scheduling concerns. Do you want to dive a little bit more into the scheduling side of the house that you were talking about?
Sure.
Or jump in to some of the
apologies for the connection delays. So best laid plans. So I guess what I was trying to stay, and I don't know exactly where I dropped off, was just this idea of if you have scheduling delays, you ultimately have an access delay. You do have, I was sharing that I had, a transition from Kentucky to Ohio when I moved, and I had to wait months. And I found a job, and I was ready, and I was excited to practice, and then I still had to wait months, nevertheless, to go through licensing, to go then through credentialing, and get through credentialing until I got my Ohio license. And that's even with the fast tracking work that has been now laid out by states. If you're going to really look at making sure we can match job opportunities to clinicians who are interested in doing that, credentialing is really a part of speed. And I think it's important to view it from a patient access standpoint. And what can we do where we can embrace standards? I know there's guidelines around credentialing, but they're not uniform. And I will say, I think this is where platforms such as the CAQH application can be very helpful, because if you've got it loaded, it's validated, it's there. How do we start to say this meets our standards, and we can start to use these to help clinicians start practicing in places that they're interested in so doing, and having patients start to get that access as a part of it.
So Meredith, you had mentioned the credentialing component here. So on the best days, in many cases, it takes about 90 to 120 days to get credentialed. Most provider groups are leveraging 3.3 software solutions and or spreadsheets to manage that provider data lifecycle. And that same data is getting entered into 2.6 different systems. So I know you touched a little bit about on this. Patrick, what are your thoughts in this area?
And it goes back to what Meredith was saying about, credentialing and the fact that you've got different processes based upon geography and that type of thing. And I really think and these numbers are astounding, but they're so accurate and they're so disturbing just to even read, is that I think we need to apply a lot of the concepts, and maybe we should take notes for CAQH on this, Katie, because I see a use case coming, in which, we have, from an industry perspective, a lot of the work that we've done over the last 5 years with the patient access API and some of the other DaVinci and Karen and other use cases that have come to fruition, is we've learned very well from a platform perspective how to democratize and liberate data from platforms that, have been heavily invested in, but weren't necessarily designed from the ground up to be integrated across the board, right? But with some of the technology that we've introduced, and it's up and running today, not that there's not work to do for credentialing and that type of thing, but establishing a pattern is that we don't have to rip out all of the underpinnings immediately. It can be an incremental process. As long as we build the appropriate, connectors on top, then we can standardize data above the platforms, and then potentially really uh, take some barriers and take some abrasion out of these processes. So as opposed to, like in healthcare, we love to do monolithic stuff and do stuff at a very grand scale. Maybe take the approach of, let's be more incremental. Let's, standardize above the platforms. We may replace those later, upgrade those later, but that doesn't mean we can't solve real business problems or real clinical issues by doing that above the underlying data.
Absolutely. Definitely a topic we are keenly aware of at CAQH and working hard to kind of convene partners and come up with the right process that will streamline across the board for everyone. That being said, go ahead.
I think it speaks to the concept of waste. Sometimes when we talk about waste in medicine, we think of it as unnecessary care. I think of waste, really a lot of waste is just like duplicative. Like you did this, you have to do it again, you do it again, you do it again. And so it's not, I think it's a different way to think about waste from sort of the lens of process management, is really saying, where do we have redundancy, not just unnecessary. Like, it's necessary to be credentialed, it's absolutely necessary, but where are we doing duplicative things, redundant things? And that can be a helpful frame to really look at opportunities that are administrative in nature.
And I think, just to riff on that,
I think that's a great point.
That plays into, Meredith, the overall problem that we have in healthcare, right? In the sense that, there was a study done a couple of years ago in which about $285 billion a year are wasted because we don't share data appropriately. And that's more in the clinical setting, right? Sharing, documents and lab results and all that kind of stuff. But the same logic applies here, right? If we're not, using standardized processes or homogenizing data, is what it can be used across. We're just adding to that number. We need to be subtracting from that number.
Absolutely. There are significant complexities across healthcare, administrative, and even, in all honesty, with our patients now. Our patients are highly complex, and sifting through all of that data is not an easy feat. Meredith, I know you had talked a little bit about switching states and trying to get up and running, licensing, credentialing. That being said, there's also a workforce shortage that we are battling here. Can you talk a little bit about that and some of those dynamics?
Yeah, I think the workforce shortage really, again, is a reflection of again, multiple overlapping phenomenon. So one is, I would say, the complexity of the care that we're trying to provide has gone up. And I really want to emphasize that. Medicine has just had an incredible amount that it can now do. And we're innovating all of the time, not just in drugs, but also in therapies and approaches, and creating definitions and new treatment modalities for all sorts of stuff. And so that now means, on average, when you're looking at a patient who comes through, and I still practice, the list of diagnoses, I would argue, is getting longer, not shorter. The management for those is becoming more complex. This is driving subspecialization, which is valuable, because then what you're getting is more specific care, more specific focus on your needs. But it can then create these sort of access delays, and you're saying you don't have the sort of ability to get in because you now have so many people. I'll give you a great example. We are surviving strokes far much more than we used to. That's wonderful. But we are also generating incredible need for neurology on the flip side of that. And so we see these delays that are starting to be part of our success, is part of the challenge. And then add on top of that, though, you've got physicians the generations, the turnover. You've got actual shortages in certain areas. And then I will say, though, one of the bright spots of this has been the real embrace of team-based care. And so you do see a lot of practices starting to say you're going to be cared for not by just your individual physician who is your doctor, which it's really now saying you're going to be cared for by this group or this care team. And you may see people who are all part of that, and it may be several different physicians, it may be a nurse practitioner who works with that physician, but integral to that approach, which I think is absolutely wonderful, is going to have to be a technology platform that helps create that communication. Because what has changed is team-based care used to be done at the bedside. When we would round on complex patients when I was in medical school, it would be all of us. It would be like a gaggle of folks walking into the room. It would be a little terrifying, I think, for the patient sometimes. But we'd all stand there and we'd all talk about it. But now this is being done asynchronously. So you still have a group, and I can see this in the notes. I can see, the note from the call where the patient made the call, and then you've got the note sent over to the mid-level who may have been triaged to that call, and then they sort of go back to the patient, and it's tags to the physician. It's all saying asynchronous. So you have to have a platform that is not just connecting this team, but helping to coordinate this team. I think that becomes even larger when you're starting to coordinate at population health levels. So you're trying to integrate community-based organizations. So you're trying to look at other non-traditional providers as part of addressing the needs that are driving health outcomes, particularly some of those social determinants of health. So technology becomes foundational to the care model, and I'm not always sure it's been thought of as that foundational level partner as much as I believe it needs to be.
Absolutely. Great points. Patrick, do you want to chime in on the tech side of the house?
Yeah, I love riffing on what Meredith's saying there. So, just to add a little bit of technical perspective to that is, the concept of a care team, right, as Meredith said, is absolutely critical. And I would actually throw the caregiver in there too, Meredith, somebody that may not be clinical, but providing whatever. And so we've been talking on the on the technical side for years about a shared care plan. Matter of fact, we have modeled one in FIRE, right? And the bringing the use cases that clinicians really need and the technology that can support that is imperative. And I would argue that although some may call for one massive platform to handle all of this, I would say that as long as we have shareable components or shareable care plan that can pass between, you have an underlying platform that supports partly manifesting at a caregiver and what a caregiver needs to know and what a nurse practitioner needs to know and what a neurosurgeon needs to know. But underlying that, we are technically managing a shared care plan. And I think, we've been, again, going back to the interoperability where we've been talking about it for a long time. We've done some great implementations, but at this point, it needs to progress to a new set of use cases in which we're solving problems like Meredith described, because the technology is not far off. It's been modeled, it's been tested in, laboratory settings or whatever the case may be, but we've not got, as of yet, industry consensus to connect at that level, and that's what we need to do.
And I will, if I can, also then just continue to riff a bit. I think everything's about trade-offs, like intention and trade-off. One of the trade-offs, though, that has developed is the volume of data you now have to sift through has gone up, right? I am of a generation where I still remember the binders, of sort of like, here's the notes. I couldn't imagine what the binder size would be now if we were to actually have the printed equivalent of what it is you have to sift through. And so the ease has also created volume. So now the volume itself has started to become a challenge. And it's interesting, we think through technology transition from paper to digital. We're now starting to think about digital to AI. And what does that look like? Because I think that's contributing to a lot of the burnout. You hear this from clinicians, over and over again. They're like, it's the paperwork, it's the paperwork, it's the paperwork. They don't mean the paper so much as the clicking and the sifting and the sort of mental triaging and sort of reading half a dozen notes to sort of figure out what's going on. I remember I took my mom to go see her primary, and this man was a whiz at figuring out what had happened to her. But I'm watching him sort of navigate this while he's talking to her, and his focus is split, and there's a variety of, he's doing 2 cognitive tasks at the same time, which is extraordinarily impressive. And how do we, I think there's a lot of interest in using AI to simplify this, as Patrick said, to sort of present the relatively important information. That, though, I think has to be married with processes that build trust. So we see this in some of our consumer insights information around, hesitancy with patients around, what is it that they're not seeing? Where do we still need that clinician review? What does it mean to display something, but how do we know that it's holistic and correct? And I think those are conversations that are also healthy to have around, we do need to start to get augmented support. And so you're seeing this move towards augmented decision making, but what does it look like to make sure that that is still in a high trust environment?
Absolutely. I think really great points all around. Some of the organizations that I've worked with, especially as we're trying to start to look a little bit further toward preventative care, to your point, Patrick, those care plans, everyone seems to have their own, and then they're not quite shared across all those different arenas to keep that full care team in the loop, including the caregiver, right? And make sure that all of those components are connected. I think what we're really starting to dive into here a little bit are some of the solutions. And I think with so much emphasis on some of these new tools, how do we ensure that our innovations are simple, scalable, solve real problems in the current healthcare landscape? Do you want to start with that, Patrick?
Yeah, absolutely. So this is where I think the patterns that in many instances have been pioneered in other industries. I know in healthcare, we tend to think that it's healthcare, it's different. And in many cases it is, because, Meredith is actually treating a human being. I totally get that. But that doesn't mean that we can't learn patterns from other industries. Like, for example, if you're like me, you wait till the last minute to do Christmas shopping. I do it on this, and it arrives 2 days later, and it takes me no more than a couple of minutes. Well, maybe more than a couple of minutes, but it's a very easy experience, right? Versus what we do for prior authorization or scheduling or credentialing in healthcare. So taking patterns that exist in other industries and actually using a true product mentality. Again, in healthcare, we tend to think monolithic applications, but in the world in which we need to make sure that we have products that are actually serving the purpose. And I've been as guilty of this as anybody. I've implemented many initiatives over my career with interoperability, going into EHRs and that type of thing, giving myself a pat on the back because that surely helped a provider, be more efficient. And maybe I actually caused them to do a few more, to be transparent, right? Hopefully I didn't do that too often. But making sure that we actually understand, what the product market fit needs to be and address things from an MVP perspective, right? It doesn't need to be perfect initially. It needs to be directionally aligned, and you adapt and learn and you iterate on that, right? We all agree that we have a very high burden in healthcare for consent and security, and we'll certainly factor all of that in. But we need to borrow from e-commerce, right, which makes things very easy for all of us, and also the banking industry, and the sense that they have very high, very secure, needs as well. But it is really simple to transfer money via Venmo these days. I don't know if anybody's done it, but it's a really easy process, a couple of clicks, and I have complete trust in that. So not only have we borrowed the underlying technical underpinnings, because the underlying technology that we use with FHIR and other things was developed, or not developed, but the foundational components were built in e-commerce and other industries with RESTful APIs, and we've taken that and applied it to a healthcare perspective. But I also think taking some of their delivery models as well, product mentality, MVP, making sure that you're actually adding value before you deploy that, right? So anyway, that was a bit of a ramble, but that's my initial thought.
Thank you, Patrick. Meredith, what are your thoughts?
Yeah, I first of all, I just totally agree with the concept of learning from other industries. I think it's important. I think innovation happens when you take something that works and you apply it in a new space. And I think it's important because the way your current operating modality has been built for a reason, because it works for some extent, or it's protecting something really critical. I think in healthcare, it does matter because we are dealing with people's health, their privacy.
May have lost.
Yeah, I think we lost her, Kenny. So maybe just to add a little bit onto that. Another key concept, and you think about, again, the beauty of what happens in e-commerce is the fact that everything is integrated. It talks to your bank, it talks to your credit card company. You're clicking on one pane, and it's being orchestrated across the ecosystem, right? It's a very nice, easy experience. We need to try to get to that in healthcare as well. The other key thing, and we might talk about this in a few minutes, is again this concept. If it doesn't have to be revolutionary, it can be evolutionary. And we talked about data democratization and liberation, right? And the fact that Amazon literally does thousands of releases of software a day. It's continuous integration, right? They're not ripping out their back end every time they're doing a new deployment, right? They're doing incremental builds and delivering value very, very quickly. So you don't. I'm not saying that back end systems don't have to mature and change over time, that they do, but you don't have to rip them out and do multi-million-dollar revolutionary changes, given the technology that we have that abstracts the web UX or the UX experience from the API layers. So sorry, it was a bit of a ramble, but it was important.
Absolutely.
Meredith,
do you want to add on to that?
I'm just going to acknowledge the interesting moment of trying to talk about interoperability and being disconnected at the same time. So I feel like a point has been made for me in terms of the simple things matter. I was just acknowledging, I totally agree with that. We got to learn from other industries and bring those in, and then, but also understand and protect what you're trying to. Why was your system built the way it was, and what is it that it's trying to protect to ensure that goes forward? One of the things that I think is interesting is, again, it's tempting to focus on the complex use cases. It's the simple bulk ones, though, that really are the low-hanging fruit. Like, again, we sort of go back to credentialing, or just sort of like basic patient information. And what does it mean to say, I think, an interesting model is the TSA PreCheck one. Say, okay, they did credentialing essentially. They're looking at how things work, and then they recognized they were trying to screen to create security, which is an important goal. And then they created a fast track. Now, in order to do that, you had to go through extra hoops. You had to get, extra screenings and checks, and there's probably some exclusions requirements. So not everyone's eligible, but it did create a way for those who are sort of frequent flyers to start to get access and be more easy. And so some of the way I think about it is sort of to Patrick's comment around, we sort of think in bulk, is how do we also just start to think in terms of, common versus uncommon? What is that, core versus edge cases? Where do we focus on creating fast tracks for those who are willing to go through extra hoops versus sort of non-standard? I think that those are going to be sort of just different ways of looking at the problem, as much as trying to come up with new standards themselves. Is sort of new pathways within those standard frameworks that we've already developed. And I think we can also look at, this is credentialing burden. Sort of how much credentialing you're requiring is going to create more delays, because you're going to have to keep and track and manage more and more stuff. Now, I acknowledge that all of this was done to try to drive quality, to really try to drive quality from the hospitals and for the providers, and really create, again, trust. That goes back to that trust component from a patient perspective. And I believe that the American training and development system is the best in the planet. I really do. But it is also starting to create, sort of more and more and more. So what does it mean to create fast tracks? What does it mean to do things quicker? Not giving up the volume, but maybe making it so that it can sort of process a little more efficiently. And so those are I think the ways I think about the volume versus speed tension that we're trying to navigate.
I think that's a great point. And actually would love to transition us to a poll on this concept. So we've been talking a little bit about evolutions instead of revolution. So we're going to put a poll up. Curious from everyone's thoughts here, which industry model, if adopted in healthcare, do you think would most practically evolve provider credentialing? So you've got what Meredith had touched on from the airline perspective, a TSA kind of pre-checked style, streamlined verification. You've got education with maybe a common application and supplemental forms, banking, a centralized credit score like system for credentialing verification. You've got tech with a single sign-on style, kind of universal credentialing access. So poll is open. Please take the time to jump in and we'll see what folks think. Give people about 30 more seconds. See some more responses coming in. All right, let's close our poll and publish results. All right, so folks here thought 47% thought a TSA pre-check style streamlined verification would be the way to go. 18% thought education common application with supplemental forms could be an option. 12% thought banking like a centralized credit score, and 24% thought single sign-on style universal credentialing access. Patrick, do you want to touch a little bit on the concept here of single sign-on and some of that universal credentialing access and how tech may be able to support?
Yeah, and that would be the underlying patterns, that were described on the sheet there are fairly common, right? We talked about them here, TSA pre-check, and everybody uses SSO in your day-to-day work. I think that given that we can support that from an industry perspective now, it's not implemented universally, is a given, right? That's table stakes. I think where we need to focus is the fact that the underlying data, right, regardless of where it's stored or what the underlying data structures are, how do we represent that at one layer above so that a common technology such as SSO or TSA type model and credentialing is able to operate on a standard set of data regardless of the underlying data structures. I think that's key because changing all the underlying data structures is significant work, right? But taking that one layer up, and we do this today, it doesn't require AI, although AI makes a heck of a lot, easier, as what we did, from a health plan perspective and an EMR perspective over the last 5 years, is learn how to represent data that's locked in these sometimes classic older systems and represent that using modern constructs. I think the pattern is probably similar here, so that you have that workflow piece or the credentialing thing that is anticipating a certain format, and then we've got a layer that ensures it's getting that regardless of what agencies or what health plan or whatever the bodies are that are doing that credentialing can access. And I think you should put that on the CAQH to do this.
I will talk with the product. We actually do.
Yeah, I mean, the only thing I would add, I mean, obviously I sort of showed my cards in terms of which one I think matters. But to some extent, it's all of the above. Anything we can do. I would just emphasize the extent to which we have here on this call representatives from insurance industry and also provider. But I also think we want to really make sure we bring our regulator community into this conversation, or the states. Because if we think about the data that's underneath, particularly if we're going to include clinicians, a lot of clinician data is held in state databases, again, credentials themselves, licensing. I would also add our governing bodies into this conversation. So if you think about, like, I have credentials through ABEM of American Board of Emergency Medicine. There's going to be credentialing, that I have again through the state of Ohio. So I think the biggest gap we have is when we don't have every relevant party at the table to ensure that we can sort of move it. It's like it's trying to find a key, and the key is like five-sided, and so we want to make sure we acknowledge the true complexity of the ecosystem, but also, where do we do have opportunities to work together to create interoperability between private and public as much as interoperability between provider and payer.
Yep.
Absolutely.
And I will say, just to riff on that,
Patrick,
yeah, state agencies are really, like Medicaid agencies are really getting into FHIR and standards-based interoperability. Hopefully that will become infectious in a good way to other state agencies that'll start adopting some of those standards. But the pattern, and it's been just amazing to watch how
I think we lost Patrick this time. All right, we will come back to Patrick. Oh, there he is.
I think Meredith kicked me off.
I did not, no. I'm not technological of anyone on this call. I promise you that.
Patrick, you were talking about making sure the regulators were involved in.
Yeah, just making a comment that especially in state Medicaid agencies, their appetite for using these standards-based models has been just fantastic, right? So they've really started adopting and being very excited about it. My thought would be Meredith is referring to. Hopefully that appetite for that type of integration is infectious across the state agencies and other regulators as well. I know from a federal perspective, they're all about it. So anyway.
It's a great point. And I think a lot of what you're talking about here and what we've been touching on is some of the data exchange, right? The underlying data architecture, which you mentioned some technology opportunities there. But what lessons can we learn from past innovations to improve the adoption of some of these solutions? Meredith, do you want to touch on that one first?
Yeah, and just sort of before we do, I do want to do one just sort of caveat with all of this, which is I think the role that has started to emerge as we talk about interoperability has also been security. And so as fragmented systems by their nature are harder to hack, decentralized systems. And so we've had a layer of security in our data that has been just by the nature of the fragmentation. As we try to address these problems, I just want to bring that concept to mind because data security is now obviously also an issue if we think about, even just like the airline, right, where it was all of a sudden like I think it was like Delta couldn't schedule for a day or something, and so there is a trade-off between doing the right thing, but then also recognizing the benefits of the system that you had and making sure you bring those benefits forward. And so you are starting to see now these chief security officers or security informational officers or CISOs come forward. And I think those are going to be interesting roles also. And so it's an interesting parallel to me in watching as the complexity of medical care has expanded. The team has expanded, right? And so now it is a team of physicians and nurses, and now pharmacists, and now social workers, and now care managers, and community providers. And similarly, we are having complexity that we're trying to address on sort of the data interoperability side. So for just again recognizing the folks on the call, I think these are interesting and important points to think about, because last thing we want is to have misrepresentation of the credentials, which I spent a really long time trying to get, and I want to make sure that is protected as well. So in terms of adoption, though, I think the point I made speaks to some of the comments that I was planning to make, which is this idea that I think true innovation, for it to take off in complex worlds, requires solutions that are multifactorial. Single solutions for complex problems don't tend to scale. And the best story I have for this is one from medicine's history, if you'll bear with me. So if you think about medicine in like the sort of the late 1800s, early 1900s, really in the early stages of being able to, develop incredible therapies, anesthesia becomes developed and anesthesia just takes off. It is adopted widely. It is embraced. Some of the first specialization we see is in anesthesiology, and it does an incredible amount for the physician, for the patients. They're no longer suffering. The flip side was gloves. So gloves were not standard. If you go further back, for doing surgeries, at some point there was a recognition that gloves would create better outcomes for the patients. There would be less infection. You had protection for the provider so they don't get infected. Gloves were resisted and took a long time. And so the question is, what's the difference? Why? And they both did amazing things for the patient. But anesthesia also solved a problem for the surgeon. The surgeon with anesthesia now didn't have a patient who was awake and suffering visibly in front of them. They could take their time. They could be thorough. They could be diligent. They could actually do the surgery. They could do more complex surgeries. It opened doors. It solved a problem for the surgeon and the patient. Gloves, when they were first introduced, and again, these are not today's gloves. They were probably bulky, they were thick, and what you saw was pushback from the surgical community. Says, I can't feel what I'm doing. I can't sew. It's making my job harder. And so it took gloves to change and innovate. And now no one would ever operate without gloves. But the product itself had to meet the needs of a secondary user for it to be widely adopted. And so I think there's been a lot of focus, rightfully so, on the patient and what their needs are. I think we have to also, though, if we really want innovation to scale, to do what Patrick was really emphasizing, which is that true product lens, that true product approach, but bring it to the other parts of the community and say, what are their needs, not just their needs to service this patient, but their needs in and of themselves to do their job, to do their role, to do it effectively. And those are things that hit those sort of sweet spots, that kind of Goldilocks zone, really are the ones that you see broad adoption.
Awesome, absolutely. And I think given where we are on time, we'll move into Q&A, and then we'll come back and wrap up. So we did have a few questions come in. This one is a good one. Patrick, I think this one is for you. So MVP perspective question. So please explain a minimal viable product. What does it mean, and how were you speaking about it?
Yes, so that is a great question, because I probably just rattled that off, MVP, minimum viable product, and didn't explain it. So the concept of a minimum viable product is in a product mindset, means the base product, it provides value, it's doing what it needs to do, but it doesn't necessarily have all the bells and whistles that it may in the future. So the concept is, you're adding value, you're interjecting something, or the value stream is active, meaning that Meredith is getting some efficiency in her clinical system, or she's getting some piece of data that she didn't have before. It's helping her be a better clinician. But it doesn't mean it's the entire picture. The MVP is the base model. It's working, it's adding value, but it also provides the underpinnings to add additional features in an iterative manner, right? That is opposed to what we used to call the Big Bang implementation. We try to get, build a Lamborghini, out of day one. You hope it works. You may not sell a lot of them because they're really expensive, but it looks good, right? But it may not get the value that you needed because you didn't test and learn with an MVP. The MVP may be a Ford. I'm not going to say a Ford Escort. That's probably a really bad example. But a base car, right? A small SUV that gets you from point A to point B. It's got air conditioning. It's got a radio. It's got enough that you need to get there. Could you be more efficient if you could maybe make phone calls or do other things in that car? Yeah, but that may be a couple of months later. So that's the concept of an MVP. And what it does is it protects stakeholders, because the folks, the clinicians, the health plans, regulators, government agencies are all involved as stakeholders in what the definition of that MVP is. So when it's met, you should see value. And if you're not seeing value, you've missed something and you go back. but you haven't completely disrupted the entire universe doing that. It's also a lot cheaper to build that way, by the way. Yeah.
Yeah, and I think MVP is very common for tech to leverage, less common probably on the clinical side. Although I do think from a clinical services and even product perspective, in my experience, building for an MVP is highly valuable. What's the thing that you can get out the door, that you can test, that you can get feedback on, and then iterate thereafter? We do have another question. So what is your experience and thus learnings that you can share related to connecting health claims administrators and providers for smooth pre-authorization and eligibility? Who wants to take that one?
I can take a crack at it. And Katie, you were breaking up there for a second, so you may be next on the list. But so I think the question was for prior authorization and eligibility.
Yeah, so what's your experience and learning that you can share related to connecting health claims administrators and providers for smooth pre-auth and eligibility?
Gotcha. Okay, so I'm gonna take eligibility in twofold. I think they may mean just eligibility for coverage. So what we typically call an E&B, eligibility and benefits transaction, which is a classic, HIPAA transaction was developed in, it's been modernized, but more than 20 years ago at this point. So, that the technology where a classic eligibility and benefits is very mature and very reliable, actually. So it typically runs on the more established administrative transaction networks, such as an Availity. There's others out there as well, but basically you have providers that are connected into a network, either in the EHR. There's other ways to do it. It could be the PMS or the hospital management system, even a phone call or whatever if you really need to go old school. But typically those transactions are run through an aggregator, and then they're shot to in real time sent over to the payers, and you get a real time response. So that is a very mature technology, and quite honestly, since it is so reliable and so mature, it doesn't get a lot of inspection today because it runs lights out. Now we have talked about, man, we should modernize that, using a fire transaction or something like that. But in reality, there is a fire transaction that does it. It doesn't get much use because the standard transaction works. I think the more important part of the question, at least I'm going to answer the questioner meant it that way, is prior authorization. So I've been working on prior authorization for most of my career. It has been a sore spot for me because it is such a painful model going back to its inception, right? And I was around in the days when it was phone calls and fax machines and profanity and all kinds of just bizarre stuff. Now, over the last 3 to 4, and there is a transaction out there, HIPAA called it, a 278 transaction, but it doesn't solve the problem of pending auths, right? And requests for additional records and those types of things. So you can run a prior authorization request all day long via those same channels, Availity or some of the others in that space, and get a response. Either you're approved or you're pended, right? And if you're pended, then you've got profanity. Some payers have gotten really, really good about making sure that only a very small percentage of those are pended. But when they do, that's where the problem comes in, because you've got to get medical records and that type of thing. Also, there's the case of, is prior authorization even required? Because a lot of providers will do a PA request because they don't know if it's required and they don't have time, they don't want to even call. It's more efficient for them just to do it. The thing that's really exciting over the last couple of years is some of the work that's coming out of the Da Vinci group and what it does is it bundles the best features of a classic prior authorization request, meaning is prior auth even required? That's step one. And you basically use one of those APIs that I've been talking about to say, is prior authorization even required? And if it's not, then you go on with your happy day. If it is required, then there's a series of transactions that happen behind the scene to build the prior authorization, and also any clinical documentation that may be necessary, like an ICD-10 code or whatever, that so that you don't have, so that you have enough information on the request side that you don't have to go back to the provider and ask for additional records, right? Now, you still need to apply the concept of minimal necessary and all that type of stuff, but it does streamline the process significantly and reduces a lot of phone calls and requests for records behind the scenes. Some of the studies that we've done on the health plan side is we did a study, this is probably 3 years ago, in which a prior authorization typically took about 18 minutes, right? It was 18 minutes on the provider side. And the incremental cost to a provider just for prior authorization was about $40,000 per year for a single clinician office, which I know, Meredith, that's very unusual these days. But it goes to show that it is not a trivial cost, right? And so that 18 seconds went down to about 18 minutes went down to about 2 minutes using some of these new use cases, because it's all baked into the EHR, and the EHR is communicating, when the order is requested to the payer in real time. Is it required? Oh, here's the information, am I approved? So anyway, there's been a lot of progress with that. Hopefully that answers the question.
I mean, the only thing I would just sort of add to that is one of the things I support at Oscar is our benefit design, and Oscar is very, very forward in thinking about trying to build benefit packages that are around conditions and communities. And so one of the things that is true is a PA list tends to be sort of fairly standard. This gets into the weeds of like even formulary PA, what does that look like? But one of the challenges we have is when we have a single prior auth list, it actually precludes creativity from matching benefit design to clinical conditions. And so there's interest, and Oscar's very interested in trying to solve this, because if we can make it easier to understand what the PA status is, what we're also looking to do is to open up the opportunities to figure out how to tailor PA lists to benefit packages. So you can say, okay, if you want to build a benefit package that's really consumer focused and really we have like diabetes plans, how do we start to say, for these particular plans, we're going to be able to really sort of move some of these guardrails because we're building a program around this condition. And in other plans where that's not the focus, they're still there. So we can still try to make sure that we create an affordable product in the end of the day for folks who are trying to still balance accessibility and affordability, which we haven't talked about as much, but is still a crisis in American healthcare. And so I think there's a lot of interest. Again, it's sort of like the win is in the weeds is increasingly what I find in healthcare. It's not these grand strategies. It's really it's rolling up your sleeves. It's getting into the weeds of sort of data, interoperability, connectivity, because that also enables creativity, and that enables ultimately the capacity to personalize, tailor. Because I think that's some of the challenge that folks have is they're having to buy these benefit package products that are kind of generic. And so they're looking for better control over their own spending, and how does it tailor to their particular health status, similar to how they're looking to tailor their health plan, or not their health plan, but their like care plan, their care management plan, to their unique set of combinations and individuals.
Absolutely. And I'd be remiss if I didn't mention there is a link to the CAQH index underneath our pictures, I believe. So CAQH's goal is really much of what we've been talking about today, right? Streamlining the experience, optimizing operations, reducing those industry costs, and ultimately keeping care at the center. So really hope that everyone gained some valuable insights today. We have just 1 minute left here. So Patrick and Meredith, what are 1 to 2 words that you would choose for all of us to keep in mind as we continue to innovate on these simple things? And briefly, why is that your word? Go ahead, Meredith.
Oh, it's hard to boil it down, but I would say it's quality and timeliness. It's saying we want to have something still as high quality and as high trust as we've invested in our system so far, but we want it in a more timely way. It's taking too long to get that high quality service, answer, care, whatever it is.
Thank you. Patrick.
And I'll go with simplicity, right? Bottom line is we've got to help patients, members reach their best health, but meet them where they are. The system is just too complex now, and that simplicity includes interoperability, data sharing, health consent management, all the stuff we've talked about today. But for me, it boils down to simplicity.
Amazing. Thank you. That is all. Thank you, everyone, for joining us today. We really appreciate your time.
Thanks so much to our speakers, and thank you for that great presentation and for sharing your thoughts with us. Thanks again to the audience for participating in today's webinar, and this does conclude today's presentation. Enjoy the rest of your day.